thank you for joining us today. This is, for those of you new to Zoom, hopefully it's pretty intuitive, but if you are new to Zoom, just note that we're going to be stopping and creating spaces for questions, but you're free to write them in the little chat box. So if you click on the chat icon, you'll see a space to type. And yeah, so we'll get started. So this is a discussion about work that's underway. It's starting to build research capacity in primary healthcare in Manitoba. So I'm Patty Thill. I'm a faculty member in rehabilitation sciences, and I'm presenting today with Alan Katz.
Who's me? So I'm faculty member in both family medicine and community health sciences, and the director of the Manitoba Centre for Health Policy, and come to this particular process primarily as the science lead for the Primary and Integrated Healthcare Network, which is funded by CIHR through the SPORE initiative. So lots of technical language there that some of you on the call actually are aware of, and if you're not, it doesn't all matter at all.
So we're here today to review steps and discussions that have happened to date about how to strengthen primary healthcare research capacity in Manitoba. We'd like to discuss some of the strategies that have come up so far, but by no means are these final. So this is also an opportunity to give some feedback on where we're going and a way to get sort of connected in. And we would like to, yeah, as we hear your ideas, it'll help us sort of integrate them for what we once thought was going to be a June meeting, but now is likely going to be postponed, where we'll come back together in an in-person meeting to move to a more established strategy. So just a mention that we are recording this so that people who aren't able to be here today can see it. We will give you information about how to access the recording if you'd like to review it later, or you know other people who should review it later. So this is a really busy slide, and I don't want to belabor it at all. But the key points are that research capacity, so the ability to do research, in this case in healthcare, exists at multiple levels. So it can be at the individual level, your capacity to engage in this kind of work, and then go right up to institutions and networks. So they're just different sort of levels at which capacity exists. And this is a model that by Joe Cook, which synthesizes literature, policy documents, position statements, a lot of studies that actually evaluated research capacity and research capacity building strategies, as well as building on the experience of one very large UK unit. So the arrows are 6 key aspects of research capacity that operate at every level. So things like skills and confidence building through training and opportunities to apply skills with mentorship or supervision and across professions, as well as in a range of research approaches. Research that is close to practice, meaning that we do research that is useful to practice because relevance helps new knowledge move into practice and policy. This is also helpful because research skills can support practice level quality improvement approaches within healthcare. So even if it's not formal research, it's still these skills have some transferability to other sites and other types of work. We create linkages and collaborations across sectors, across geography, across industries, enhancing both the research team's knowledge and skills and also potentially increasing impact. We ensure appropriate dissemination, or what we would now call knowledge translation or exchange. So continuity and sustainability is about that longer term ability to continue this work, as well as the infrastructure that goes into that. So what kind of supports do you have built in? So why now and why do this at all? There's this really enduring finding that strong primary care systems, primary care is part of primary healthcare, but not all of it, that strong primary care systems produce better and more equitable outcomes at lower cost. So we can actually kind of have a win-win there. we know that research is required to produce an evidence base for decision making, whether that's in policy or practice. Health system change, we're in the middle of health system change right now, what the province calls bold system change. And we know that that creates lots of opportunities to research and learn, as well as support system change in terms of evaluating what's working, what's not, trying to innovate new ideas of how to do this. And the other reason why, and this is sort of my personal reason for getting involved with this work, is that there's a new wave of faculty hires in Manitoba. So there's, I can name 7 in my own college, and that's a smaller college. So there's so many new people coming into Manitoba that have interest in this area. And so particularly for those of us that aren't from Manitoba, creating stronger capacity where people know how to link in and connect and have work across collaborations, et cetera, helps those new people use their skills to the benefit of Manitoba. So we've already, back in November, we hosted a meeting, which Alan will tell you a bit more about in a moment. And that had 3 specific aims. And it was to start building and strengthening relationships among those involved in primary healthcare in Manitoba, to assess or identify existing primary healthcare research capacity here and identify opportunities for growth, and to initiate the development of a plan to strengthen primary healthcare research capacity in Manitoba.
So just to share with you why we're here today, before we go into what happened in November, one of the things that we agreed to was try and reach out to as many people as possible that couldn't potentially make it in November as an opportunity to share what happened at that meeting so that people will be aware of that. And also then for those of us who were there, and I know that there are a number of you on this call, to rekindle some of the energy that was generated at that meeting. And there was significant energy generated, and I'll describe some of that, and we'll both get into that in a moment. But just to go back and revisit some of these things and have the opportunity to build on what happened and share our ideas again. I'm sure that since that meeting, those of you who were there, other things have come to mind. And of course, those of you who weren't there, we're hoping that you'll be able to share some of those ideas with us today. So November, what happened? We had what was an invitational meeting. So because of the costs of renting space and meals, et cetera, we did limit the meeting to about 50 people, and we had 49 on the first day and a few less the second day. 2-day meeting. And we invited a whole range of people, including researchers, clinicians, policymakers, and patient and community partners. And I will say that being both a researcher and clinician and working very closely with policymakers for a number of years now, the highlight for me was the impact of patient and community partners. And they really did influence the events on that day quite significantly and in a good way. So when we planned this, we recognized that there are a lot of good people in Manitoba. We've got a lot of good ideas. Primary healthcare research in Manitoba is, as Patty said, really taking off with a group of new researchers who've recently been hired, people with relatively recent PhDs. And there are also a number of people who've been around a while, like me, who've been trying to do this and are now recognizing that we've probably got a critical mass that we may not have had in the past. But we also recognize that it's really important, and this was really Patty's initiative, and she put in a bunch of funds for this, that it was important to bring in some external ideas to nourish us with other people's experiences and what they could bring to the table in helping us develop our local initiatives. So we had 3 guest speakers. One was in person, and the timing of the meeting was to, in fact, exploit the potential that all 3 would be in Manitoba, would be in Canada at that time. We did this following on from the North American Primary Care Research Group meeting, which was in Toronto, I believe, earlier that week. And so we were fortunate to be able to have Grant Russell from Australia with us in person from Monash University. The other two speakers who were invited both intended attending the meeting in Canada, but for personal reasons, it turned out that neither of them were able to attend. So we struck out with 1 for 3, but not too bad considering that these were all high-powered speakers, and we did get them to talk to us via video conferencing on the day. So Grant is somebody known to many of us. He spent a number of years he's originally from Australia, and he went back to Australia, but he spent a number of years in Ottawa in particular, and got a PhD from Western University as well in primary care research. And he brought a wealth of experience that he was able to share with us. He spoke extensively about Cook's model that Paddy has presented, and gave multiple examples of building research capacity and his own experience in doing that, and very successfully, I may add. So very inspirational. He also was around for the full 2 days and was able to continually contribute his experiences and help ground us in practical experience. So I'm not going to go into detail of what anybody said, other than to share with you the big outlying pictures of what they spoke about. The second guest speaker was Anne MacFarlane, who's from Ireland. And Anne spoke about her experience with regard to community involvement in primary healthcare research. And she actually had some really fascinating experiences with regard to working with migrants in the UK. Very topical, and once again, lots to learn from her experience and bring down to what it is we can do in Manitoba and where we should be going based on that experience. So patient-oriented research has been recognized by CIHR already for close to 7 years as a priority, and there's a significant amount of funding that's been put into patient-oriented research in Canada by CIHR with a number of initiatives. The network that I'm the scientific lead on for primary care-oriented research is funded through CIHR and through the strategy for patient-oriented research, and is now up for renewal over the next year or so, as are some of the other initiatives that were funded with something like $60-odd million over that 5 to 7 year period. Number of chronic disease networks, and of course the SPORE support units, which are situated in each of the provincial jurisdictions, one in Manitoba, where the unit providing that role is actually Centre for Healthcare Innovation. And we are now working with that unit as they start developing their renewal for funding over which was to be due in May, and that has been delayed now until July due to the circumstances and reality which we live in. So that's a change that we will live with. The third guest speaker, Jean-Fred Levesque, is originally from Quebec, as his name might indicate. He's been in Australia, I'm thinking also 5 to 7 years. I've worked with Jean-Fred for many years, and he started off doing family medicine and public health, took a leadership role in public health in Quebec, and is one of those people that is a very, very high-level, broad thinker who really challenges people to think of things in a different way, and is currently the Chief Executive of the New South Wales Agency for Clinical Innovation. So New South Wales is the Australian state that includes Sydney. So Jean-Fred's talk was very high level, challenging us to think about primary healthcare research as we move forward, and broadening the context beyond Manitoba, beyond our reality, but to look down the road, what may be coming down the road. Unfortunately, he did not think of a pandemic as something to think about for primary care research. Not surprising, although we know that Bill Gates thought of this 5 years ago as coming down the pipe. But nevertheless, Jean-Fred's presentation was very stimulating, very challenging in terms of looking at what are the things that can help us understand firstly, where primary healthcare fits into the healthcare system. And that's a great example of how the healthcare system has pivoted dramatically to COVID-19. And we in primary healthcare have also pivoted to that in terms of things that we're doing around providing virtual care, which was not really part of primary care in Canada until some 2 weeks ago. And yet I can tell you that within the family medicine component of this, in my clinic, 2/3 to 3/4 of our current care is provided through telephone care. We don't yet have all of the capacity to do this through video care, but we're hoping that will come. But this is an example how care pivots to the circumstances, and obviously there's research opportunities that arise as a result of that. There are new ways to use healthcare data because there's new ways of data coming about at the same time as part of the pandemic. So once again, there he was actually predictive in terms of what we'll be dealing with, and recognizing that the universality of care that's provided needs to be seen within the context of personalized medicine. So bringing together the need to recognize the needs of each of us within a universality system, and to join a national, transnational research approach to how healthcare is provided. And one of the things that did come out, and you'll hear about, that I think was influenced and certainly highly relevant to what Jean-Fred had told us, was the whole issue of recognizing that people have needs based on their individual circumstances, and we in Manitoba need to recognize that and to start moving in that direction in a bigger way, particularly with regard to people who live with challenges with regard to geography and racism and colonialism in the past. And the learning healthcare system is something which has been promoted for the last year or so within Canada and internationally. Much of the early thought actually came from the UK and the US, but we now, this has really, Canada has brought in a big way, particularly at the CHR level, to the learning health system. And one of the requirements of the renewal for funding that's come out from CHR for the support units, and in our case CHI, is that one of the foci is on the learning health system more broadly than just primary health care, but we need to do that within primary care as well. And one of the other foci is also on use of healthcare data. So while I jokingly said that Jean-Fred did not point out the potential for a pandemic as the place to go, he was pretty spot on with some of the early developments that CIHR is moving towards in terms of those calls for proposals. So these were three very stimulating conversations. The second two with Jean-Fred and MacFarlane were less of a conversation because they were not in the room with us, and it was difficult, so we could not have direct conversations with them. But certainly I think those three presentations all really enhanced our ability to explore where we're going and where we need to be for the future. So we then moved on to something Patty's going to talk about, but maybe if I could just break there for a moment and ask if there are any comments or questions about those three guest presentations that we had on the first day. Feel free to unmute your line and join and add something if you wish.
Hello.
Oh.
I guess the challenge for me that I see with all of the priorities and the sort of shifting sands of all the things that are happening now is articulating the call to action, so to speak, these things in different ways, with the struggle to connect that to how we're going to do it when it's really not quite even certain how we're going to be, operating in the next several months, let alone several years or whatnot. So I don't know how to address that challenge. I'm just putting it out there. But for me, getting my head around some of this stuff, as someone who's been promoting the use of technology visits and the like, and for many years, I think this is in some ways an opportunity to do some of those things quickly and get on with it and stop worrying whether the server is hosted in Manitoba or not or whatnot. But at the same time, in terms of priorities, in terms of planning priorities, I find it really hard to think about when we don't really know the how. I agree with basically what we've talked about as far as being important and what we should sort of focus on. I'm struggling with the how do we do this now, and not with a lot of things remaining uncertain.
Great point, Alex. And I think that that's something that we will come back to at the end when we talk about next steps, because I think that Patty mentioned that we'd planned a face-to-face meeting in June, which we clearly are not going to have. But we do recognize that we have an opportunity now to have the very conversation that Alex has raised. And I think that our intent is to have another Zoom session like this one, probably in the next 6 weeks or so. And that may well be an important conversation to have there.
Other comments or questions? Okay, so just for a quick review for those of you who weren't there, in November, after partly through the day while we were listening to speakers, but also later, we continue to do work that identified our existing strengths and opportunities for primary care and primary healthcare research in Manitoba. We did, if people are familiar what a World Cafe is, it's kind of a good big brainstorming activity where there's a lot of movement in a room and groups engage with different questions. So based on those opportunities in particular that have been identified, excuse me, on the first day, then we asked some more specific questions. And people had the chance to brainstorm. Now, we did do some work to try to identify what might have a lot of support among those ideas, but we fully recognize there's not all the people in the room who would be interested in giving direction to where building capacity for research moves. So we started to explore those priorities. Then there were some steps by which we got feedback from participants, evaluation of how the day went, and some discussion about next steps. So based on all of that input from that meeting, members of the Manitoba Primary and Integrated Healthcare Network that Alan had mentioned did some synthesis of the various ideas which had some real support in that November group. And so these aren't final. These were just kind of it's one way to organize the ideas that came out. Part of why we're hosting this meeting right now is to hear people's ideas about these types of actions. And so this is essentially what we're going to be working to finalize in time is really a sense of what the strategies to strengthen capacity that we want to pursue here are. So while there's real distinct questions about like research questions that are coming up in the moment and system questions that are coming up, the stronger your baseline research capacity in a place, the better you are able to answer them. The better you're able to build the team to be able to do what you need to do. And so these are actions that came out at that level. What are the things that we could do? Recognizing that it's not really linear or exacting, but you just have to have enough of the resources in place for research to be able to happen. So the first was to create a coordinating center or some kind of central hub where people who are looking to connect in can connect. The second was to establish across Manitoba patient or community partner network. So to really galvanize around that, we're going to include communities and patient or public members in research. And to do some work to explicitly support collaboration among this community. And the other thing that wasn't like an action, but which was a very strong, clear-cutting principle, it came up over and over again, was an explicit commitment to equity in our work. So the work of this growing primary healthcare network, if you will, is going to have a strong equity focus. So to come back, so for the first one, there's many little things that little specific things, actions that came under it, and we'll just go through them quickly. So if we're going to create some kind of one-stop resource, we need to develop a mission, vision, and mandate for that resource or that coordinating center that demonstrates a commitment to primary healthcare research and aims to achieve better coordination of this. So essentially, a mandate might be that it strengthens infrastructure to support primary healthcare research. That we create connections. So some of us are more formal researchers. Many of you are involved in quality improvement, as well as working across health professions. There was an idea to host an annual forum that allows everyone to connect in for critical discussions that would lead to actionable recommendations created from consensus. That we develop opportunities for research training and mentorship, drawing from a range of expertise, including, for example, knowledge keepers, and a range of approaches. So everything from participatory action research to things like big data and AI type approaches. So you would have a real range in there with the mentorship and training. To do some work to streamline expenditures and reduce duplications. That we focus our projects on identified problems and gaps in primary healthcare. So we have primary healthcare reform or transformation happening right now. And this sort of connects to both Grant Russell and Jean-Fred Levesque spoke about this. Grant was talking about the opportunities to do work that is meaningful to a system when there is big change underway. And Jean-Fred's was really like drawing out some of those big things. So we do have artificial intelligence. We do have big data. We have people are using all sorts of health apps on their phone. There are just so many new technologies available. For example, there's a lot of need. There's sort of this truism that gets said a lot, which is that we're the land of many pilot projects, but we don't scale up very well. So we might have a model that works well in one place and a different one that works well somewhere else, but we don't necessarily have those comparative studies with something that Jean-Fred spoke about. So there are things like the technology-focused interests might be one of those identified problems and gaps. So including First Nation data access, digital health, EMR enhancement, non-physician data. So there's a lot of clinicians now working in primary care, but they're their charting and et cetera is not captured in systems that exist in the same way that it is for physicians. So as well as there's a new movement toward patient-reported outcomes and patient-reported experiences. These are types of measures that exist. So trying to use address these gaps and problems, using that as a catalyze capacity in the province, and do work that is both meaningful as well as contributing to a national or international literature, which is also a way to build your capacity, just to strengthen your relationships outside of your specific institutions. So, and also as well as research opportunities, some things like field placements, capstone projects, those types of things for health professionals who are both pre-licensure as well as those who have graduated and are looking for more opportunities. Alan, I'll let you speak to this one.
Before I go into the next one, I'm just going to make a comment about the last one, in that it sounds like a huge task to build this whole new coordinating center and build something from scratch. But in fact, if we think about the primary healthcare, primary and integrated healthcare innovation network, which was funded by CIHR, that network could and should, I think, play this role very well. So that network hopefully will be funded again in the near future. The funding runs out sometime in the next year. We will, if there's an opportunity, we'll seek renewal and be able to play that role very well without building something from scratch again. So moving on to the second idea, which was our relationship with community partners and patients. Once again, this is something that is not new to us, really. The SPORE initiative has really laid the foundation for this. And I think that the reason this came through so importantly in our discussions when we did all this interaction with everybody in the room was that we had, firstly, those of us who are clinicians know the work we do is for the good of our patients and our community. Secondly, in the room, we had a number of vocal community members and patients who reminded us of that fact and reminded us of some of the specific realities of Manitoba with regard to equity and access and equity and quality. So the recognition that we can do more throughout the research process in involving communities and patients from the planning stage to research questions to implementation through dissemination strategies. Throughout the process, we can and should build skills around how to work with patients and communities and support that process and work with what's currently out there. And as I mentioned earlier, was that there are multiple underserved, marginalized groups, and we've got a lot to do with regard to improving access to equitable care in Manitoba. One of the specific tasks that we spoke about to achieve this was to develop an inventory of community groups and partners who are willing to engage, which then becomes a resource for clinicians and researchers in particular to engage with, to ensure that right up front there's that opportunity, as I said, to engage with those patients and communities from the beginning prior to actually starting to even ask questions. And then as Patty said previously, there are experience measures that we can use that I think will be very valuable as guides to our system as it evolves and as transformation within primary care becomes more prominent. We need to be able to measure that. We need to be able to use those, measure those experiences, reflect them back, both at the system level, but also at the provider level. Some micro, individual clinician, practice level, meso, and system level to improve quality of care that we are providing in Manitoba. Back to you.
So let's pause here. I'm sorry I forgot to do it after the first slide. Let's just pause here and see if there are any questions or comments, anything you would expect to hear either in a coordinating infrastructure or a patient and community partner network that you haven't heard in terms of actions. Jennifer, is there anybody in the chat?
Well, I'll make a comment, but I don't want to be the only person that comments. Does anyone else want to say something first?
Go for it, Alex.
No, I was just going to reflect on what you said, Alan, about how this hub could look similar to what the SPORE network, the primary and integrated health SPORE network, sort of had initially aimed to do. And I think what it looks like to me is a bit of a realignment, right? When the SPORE network was originally conceived, it had a very specific model with the policy, research, clinical, and it, you know, came from what was in the proposal and what CIHR funded. I think what came across at the meeting and what that slide sort of represents is a rethinking of what that group could do and maybe should do. And in some ways it moves, I would argue, a little bit away from a direct relationship with sort of the policy people, but more to sort of the research support, research infrastructure sort of piece, and that maybe the policy piece is part of that, but not at the point of supporting the infrastructure. It comes somewhere different in the continuum in terms of where the research gets applied, used, implemented. So I think it's still a component, but a lot of those things on this previous slide were really about what kind of supports and services could be available that would help facilitate and allow for, you know, more advanced research in primary care. And so I agree that this could be a realignment of the way the PICI network was functioned, but it would also mean that it would have to operate differently in terms of the things that it did, and you know, it may relate to how CIHR decides to fund it. I mean, the network to a large extent didn't do a lot of those things because it had other priorities as set forth by what it proposed and what it was funded to do. So I think it means that we need to, in the next proposal, realign some of those things if we're going to take this into account and say these things are important, and therefore what do we need to put in place on the team and within the sort of structure to actually facilitate those things.
Yeah, that's my sense as well. The idea of getting to some prioritized actions, although we didn't initially design this to be about the network that already exists necessarily. They funded the initial meeting, but it was, you know, but the idea that this can support, right? These are the priority actions that have been identified as we continue to refine these and come to more agreement on them. So yeah, I think there is, it really does help that specificity in a proposal in terms of the kinds of things the network is trying to achieve. But Alan, you know, scientific co-lead, you might want to say more about that.
No, I think you're right. And I would say, though, that when hopefully there will be a call for renewal, when the call comes out, we will need to answer that call. And the proposal that we develop will need to address what CHR wants in that proposal. But at the same time, we've got this agenda which has come out of this work that we will weave into that as best we can.
That's fair.
I see that there's been some chat comments.
Yes. So we have one from Connie. As a community partner, we want to be involved at the community level. And then one from Jeanette. I'm excited to explore the application of PROMs and PREMs in primary care. This requires further development, engagement / understanding from primary care providers. I don't know if you want to speak to both of those.
Connie, do you feel like turning on your mic and talking about more what you're thinking?
Good afternoon. Can you hear me?
We can.
Oh, good. I guess for me as a community partner in Manitoba Association of Senior Centers, there's a lot of need out there to connect to the front line out of the standard research. And I've learned in the past 2 or 3 years because of projects that we are connectors with, that connecting to the front line is not always easy. And I'm thinking about caregivers right now. The number of people in Manitoba that are primary caregivers, and yet, to my knowledge, nobody's talking to them. I'm a primary caregiver for 3 people. And because I'm involved at this level, or I'm involved at the association level, I'm getting information. But there's a whole slew of caregivers out there that are not getting information or not being asked. So I'm a real advocate for asking them. And I hope that makes sense.
Mm-hmm. And my understanding is that there was a lot of agreement for that, right? That is a need. When we go back a slide, and you'll actually see in the third big topic. Oh, sorry. So actually, Connie, yeah, it will be our third big topic, which is about making sure we get out and create those opportunities to connect. So I think I fully heard that at the meeting, and that's where some of the, I mean, we've talked about these patient-reported experience measures and patient-reported outcome measures, which are like quantified, but you can also do the type of research that gets out there and works with communities in a more what we call qualitative way, while you're doing the kind of work with them and learning from, not from numbers, but from other types of data. So I think there's lots of room for that. Yeah, there's lots of support for that, was my sense.
And I need to add into the mix that the Manitoba Association of Senior Centers, with their age-friendly resource team, we're connecting across the province to a variety of folks. And I'm going to hazard a guess of all ages, because we're going into strategic planning tomorrow again around the whole intergenerational aspect of age-friendly and connecting to everybody at the community level. So as we go forward with whatever we're doing in this network, that's, I guess, a reminder or a conversation for the future in some way, shape, or form.
Okay. Jeanette, did you want to speak more to your interest and excitement?
Are you talking on mute, Jeanette?
Can you hear me now?
Yeah.
Yeah. This is something that is certainly moving forward nationally with Kai, and as many of you know, Sarah Kirby and I have been working a lot on this. We have, at a very cursory level, approached primary care, particularly as we are trying to look at ways of understanding access and the patient's perspective. And it's become apparent to me that there's a huge learning opportunity for providers. So I think there's a bit of a fear that this could turn into an accountability rather than a learning. And I think there's also a huge opportunity for us to move forward at a policy and planning level. So I can just say, and I'll put on a shared health hat for a moment, that as we're looking for really enhancing patient and public involvement, not just engagement, I think this is an enormous opportunity in primary care. I don't know if you have any comments on that, Ellen, in particular.
No, I agree that this is we need to move forward with these things. It's very exciting, an opportunity.
And I do just want to acknowledge, Pam, you put up a question about clarifying meeting between primary care and primary health care. So at the November meeting, we did do that, and I'm sorry we didn't do it today. We considered it and thought we would not add to that. The short version is thinking about primary care as that which happens within the healthcare system. It's that part, that entry point to the healthcare system, but that primary healthcare has a stronger intersectoral. And explicitly, we talked about the Declaration of Astana, which was the newest World Health Organization primary healthcare declaration at the November meeting, and that absolutely reinforces the idea of equity and social justice in the bigger across sector kind of conversations, recognizing that a lot more has impact on health than just the healthcare system.
Patty?
So yeah.
So yes, I understand all of that. My query is the language that we're using, and if we could be consistent with that, because we seem to be using primary health care as the catch-all, and we're in fact talking about primary care today as we were before. And so again, I'm just asking to making sure that that we're saying what we mean.
Yeah, I agree. Yeah. So some of the kinds of things that'll come up, and I'll move to the next slide. So this starts being, some of this is still primary care, of course, when you're talking about clinicians and frontline healthcare professionals, you're very much in the primary care realm. The idea that we need to create opportunities to bring those folks together, but also partnership across organizations, right? So thinking again, at this point, it starts becoming quite repetitious just in terms of how we, trying to figure out where actions fit under what. But the idea of a couple of things that are very specific in here are creating a strategy that works across boundaries. This has sort of the governmental ones, as well as primary care practices. You can certainly see that in terms of working across boundaries with community organizations as well. There was a discussion here specifically, one of the actions was to develop satellite locations that are outside of Winnipeg, that are in rural, remote places. So the idea that those of us who do seek to work with communities outside of here, that there is a place, like a physical place with basic infrastructure that we can travel to and work for a period of time. And as well as data gaps came up here. So these were kind of the actions as we tried to organize them. Again, anything else you would expect in terms of actions that we need to be thinking about taking to expand or build upon our existing capacity to do research.
We have another comment in the chat. It's from Phyllis, and she said her internet connection's a little unstable, so it might be choppy if she were to speak. But just a comment, is there anything positive in everything that is happening? And I am recognizing the current realities in the current public health crisis. Many innovations have spawned and gotten off the ground very quickly. For example, I'm involved in the creation of a virtual triage hub with Algoma's One Health Services. I think as an emerging network, we need to keep a pulse on what's happening right now, potential to connect researchers with those that are innovating. This fits well with the goal to create connections between research and quality improvement.
I fully agree. I appreciate that you're concerned you won't be able to speak to it. I think, and Alex's comment earlier to me kind of speaks to this as well, right? The desire to do something right now and to mobilize And this particular work to build capacity is a bit of a step, not in the wrong direction, but just in a different direction, right? Which is about our ability to mobilize quickly and to build really like quick, but also robust connections and projects, or supporting them with quick evaluation, that kind of thing. Having stronger research capacity makes that easier to mobilize. That would be kind of my big comment. So I think the idea that there are like things that we may need to be doing right now, I don't know, I'll let Alan maybe speak to what we have available within the network now to support people if they do want to look for certain resources that already exist in our connections.
Well, I think so. This is really an important conversation to have now, that we need to ground our conversation in what's happening around us. And certainly I would say that the network as it currently exists can serve with the current resources as at least a hub that people can contact when they're looking for, if they have questions, when they're looking for collaborators, when they're looking for what's happening. The world's a complicated place with lots of people trying to do different things. And I don't want to belittle that or to reduce the importance of trying to get people together, but I'm involved in at least 2 other initiatives where the same kind of thing is happening in the world of administrative data analysis, which isn't specific to primary care at all. But it is important that we provide mechanisms to connect with each other wherever possible, so that one of our goals that we spoke about was the reducing duplication. And this is an opportunity to ensure that people who are doing things can find out who else is interested in doing similar things. So what I would undertake as a result of that is to work with Gail and Alana to set up we'll send out a email address that we can serve as a clearinghouse for ideas, so that there is something out there that people know that they can address if they have questions around what is happening with regard to COVID-19 in primary care, and ideas they may have what to share in case others are interested in hearing about that.
And I just want to say thank you. I realized Wanda, I had misheard your names. That's Wanda Phillips Beck.
Yep.
Yeah. And Ruth Ann Mary asked if there's a role for pragmatic EMR-based trials. My gut instinct, but I will defer to Alan, is to say there's a role for any kind of, the methods aren't limiting. It's what answers questions that fall within primary care or primary health care is what's you know, in terms of addressing identified gaps and needs, and doing the kind of work that is valuable and needed in the system. So I'll let Alan speak more.
I'm not sure that and I think generally I would say yes, there's a role if we have ideas around what we want to study in that respect. So for me, the question is, you know, the infrastructure that currently exists through MacFarlane that Alex leads, I think can be used for EMR type studies. The question is what those pragmatic trials would be looking at. And I'm sure that Alex would be very more than willing to explore any ideas that come up, and I certainly would be willing to try and support them in any way we can through the MPN, the Primary and Integrated Healthcare Network. So I don't know, Ruth Ann, if you want to expand on any ideas you may have, or want to just leave that out there until those ideas become more.
Well, I was just thinking, I mean, I think it's an underutilized tool as we move to more electronic systems, and we are capturing information in routine clinical care, whether it's primary care or specialty care. And, you know, if we think about really wanting to move pilots into clinical practice, one practical way is to actually do your sort of really pragmatic trials. They're already embedded into clinical practice. So if they work well, it really creates a natural platform to move things to implementation. And in addition, it's a lower cost mechanism for conducting trials if you want to sort of work through a series of things around a question. So I think we haven't really use this tool as much as we potentially could to try and address things. There are lots of things that both really in the home of primary care, but also in the interaction with specialists and the kinds of questions that you know that you've been dealing with in the context of the team grant we've been doing, right? There are many questions that have come up with the interface with primary care. What we want to know is like, would this work, right? And so that would be a rapid mechanism to potentially evaluate and then, scale up.
Yeah, I agree with you. I think you're right. And I hadn't myself been thinking about that in terms of what's happening now, whether we can actually, probably without a huge amount of expense, generate some very interesting pragmatic looks at what's happening in the system through EMR. So that's something we should certainly look at.
This is Gail. I would just like to also add that in terms of capacity building, there may be an opportunity for our network to take up some of that that need for capacity building in using EMR-based data and arguably even other larger data sets. I wonder if that's maybe something that we could develop is, how do you ask questions that can use EMR data? How do you kind of, I'll use this word cautiously, but mine data that's currently out there to answer questions that are relevant to primary healthcare? So I'm kind of framing this in terms of capacity building, and there may be an opportunity here, and we may have to look at this further. So thanks for that question, Ruthann.
So we're running out of time. I just want to, there's another, EMR data. Yeah, Pam, asked a question. Where are we at in terms of being able to use data from other professionals in primary care? So I'm a physical therapy prof and Pam is an occupational therapy prof. So this is a real challenge for us and some other professions that we are in the healthcare system, we are in the primary care system, and we are using the EMRs. So it strikes me, I will defer to others to speak to this, but it strikes me that if we were working on EMR, and so the electronic medical record, for those of you that aren't familiar with that, if we were working with that information, we may be able to actually do more to capture. But my understanding of the two other big databases that sort of get information from primary care, which are MacFarlane and the MCHP, it's based on physician alone. Is that right? Yeah.
Nurse practitioner.
Yeah, so that point did come up earlier that we have to figure out how to build the infrastructure for that kind of work, because the opportunity to evaluate, for example, the impact of OTs joining primary care clinical teams would be much easier if we had that data in the same way that we have it for medicine, but we at this point don't. So I'm afraid we have to wrap up. One other question. Okay, Alex will explain it another time.
Can you just show the last slide? Can you just show the last slide with the contact?
So we're looking at deferring in January, but we want to continue to do work with you to create sort of a more concrete steps that we're going to focus our energies on. This is the committee of people that continue to work on moving this forward. And so thank you. For those of you, if you want a copy of this presentation or you want to be on the regular emailing list to find out about more of these things, please visit this website. Jennifer, would you like to describe how to add yourself to the website or add yourself to the email list from that website quickly?
Sure. So we have on the front page a fillable form that you can add your email list to if you want to be added to the list, or I'm going to add my email to the chat and you can email me directly.
So take a look in the chat if that's your easiest step before you sign off. We'll leave this open for a few more minutes just so you can copy that down. Thank you so much for coming. This is a really, I was going to say isolating period of time. It's really, we're all living through something that's pretty world changing, and we appreciate you taking time to spend with us today.
Thanks, everyone.